Welcome to the Hills. Screening saves lives, closing the gap in breast cancer care. Please begin taking your seats. The program will begin in 5 minutes, so grab any last minute coffee and breakfast. And please silence your cell phones. Thank you.
Good morning. Thank you. The camera people told me I'm not allowed to stand on the stage because I'm too tall, so I'm going to post up right here. Good morning. My name is Bill Salmon. I am with The Hill. I'm so delighted that you've joined us here on this glorious October morning in our nation's capital. It's also very nice to see so much pink as I look out across the room as we continue to spotlight Breast Cancer Awareness Month. I think the award for best pink outfit in that department goes to Congresswoman Debbie Dingell, our friend. Where is Debbie? There she is. Okay. Look, the people in this room know better than anybody else that over the last 4 decades, there's been really remarkable progress in the fight against breast cancer. And yet, sadly, this disease continues to take a devastating toll on women. Now, the good news is early detection not only saves lives, but it actually reduces the cost of treatment, right? The bad news is that still too many women run up against financial barriers that prevent them from getting the kind of access to the care that they actually need. So, on that topic, we're going to talk about something called the ABCD Act. Now, what is the ABCD Act other than a very clever acronym? It stands for the Access to Breast Cancer Diagnosis Act, ABCD. And basically, the idea is to eliminate financial hardship of follow-up care. Now, the bill was introduced earlier this year, but unfortunately, it's sort of still stuck at the procedural starting line. And you know, the thing is, it's hard to move past that starting line when you're in the midst of a government shutdown, right? I mean, we're on, what is this, day 22 of the government shutdown, and that obviously has to end before this bill or any other bill can move forward. All of which is a reminder that timing is everything, right? In not just in the world of politics and policy, but in the much more important realm of breast cancer screening, which we're also going to be discussing in today's program. But first, I just want to take a quick moment to thank our sponsor, the Alliance for Breast Cancer Policy, for their generous support in making today's very important conversation possible. I also want to mention, if you're following along on social media, which we hope you are, you can use the hashtag #TheHillHealth. Repeat that, hashtag #TheHillHealth. And now, without further ado, please join me in welcoming Kathleen Koch. She's a contributing editor at The Hill, and she's going to be leading a bipartisan discussion with a couple of esteemed lawmakers, including the aforementioned Congresswoman Debbie Dingell, a Democrat from the great state of Michigan, and Congresswoman Beth Van Duyne, Republican from the great state of Texas. Both of these women are co-sponsors of the ABCD Act, the Access to Breast Cancer Diagnosis Act. So please, let's give a very warm welcome to our panel. Thank you.
Thank you, Bill, and good morning, everyone. Thank you for joining us. You know, the numbers are really staggering, right? That 300,000 women, more than 300,000 this year, will hear those words that we all fear, right? It's breast cancer. One of my best friends got the news less than 2 weeks ago. So she's, trying to figure it all out right now. So that's why we're here to talk about screening. Screening using every appropriate method, right? Because, as Bill said, early screening generally does equal survivability. So Congresswomen, thank you for being here with us this morning, and thank you for your ongoing work on this. I know Congresswoman Dingell, you reintroduced this measure earlier this year, and Congresswoman Van Duyne, you are a co-sponsor. And I know for you that this is personal. Tell us why.
You know, we come into Congress for all different reasons, and definitely healthcare had a lot to do with why I ran. But ironically, I just got elected, so I got elected in 2020, so November 2020. Crazy whirlwind in January, right? January, February, crazy. We're up in DC a lot. We had to hire a brand new staff. We had to get, our office all set up. And I found a lump. And I was home for, 4 days? You're home for a very short period of time. And I called for my mammogram. And they asked, why do you need to have a mammogram? Is this just your annual? And I said, well, actually, I found a lump, and everything stopped. They refused to schedule a mammogram appointment for me. They said, you have to be seen by a doctor first. You're going to have a diagnostic, so you're going to have a referral. And I said, well,
Prescription.
and a prescription. And I said, well, my schedule is crazy. Like, I don't know when I'm going to be able to do that. So they refused to be able to schedule a mammogram for me. So then I had to call a doctor, and then it took me 3 months to get in to see my doctor, and then it took me another 2 months to get my mammogram scheduled. And so it was like when you need it the most. Like, the entire point of having a mammogram is to actually have early detection. You detect something, and then they hold you off for 5 months. And then, you have insurance for a purpose. It's supposed to cover your mammogram, and then I got the bill, and I'm like, holy cow. And they were very clear.
How much
was it?
was
Almost $800.
Wow.
And they were very clear, like when you walk in, they won't even let you see that unless you sign the piece of paper that says you acknowledge the fact that insurance is going to cover this, is not going to cover this, and you are responsible. Are you sure you still want to come in? Are you sure you still want the diagnostic? And I thought, this is so absolutely against any kind of common sense. And so that I get into office, I'm in my office, it's like in March or April, and folks from Susan G. Komen come into my office, and they're like, we want to talk to you about a bill. I'm like, no way. This literally just happened. This just happened. And I would not have thought that was real unless I'd gone through it. Because it seems just so counterintuitive. If you want people to have early detection, especially if you find something, get them in as soon as possible.
And cover it. Congresswoman Dingell, talk to us about that. How would the ABCD Act fill that gap?
Well, first of all, I'm not old, but I'm seasoned. And I've been working breast cancer with the Susan B. Komen Foundation and another woman that Fran Visco, who had the breast cancer advocacy, and for anyone who's seasoned like me, which may only be Bill, you will know about breast cancer at the very beginning. And people didn't say the word breast. I worked for General Motors for 30 years. My insurance plan, when I started working with Nancy Brinker and the Komen Foundation, didn't even cover mammograms. When I tried to get appointments, it was a year for a mammogram at the University of Michigan. And then when you get there, this did happen. It took me a year to get the appointment. And when I got there, I didn't have the prescription, so they wouldn't give it to me. So, but we've been working on it really hard and trying to address the bureaucracy of it. What happened to Beth should never, never, ever have happened. So, what we're trying to do in this bill is to ensure that insurance covers. So, and there's more complications to all of this too. One, insurance covers the mammogram, but if you need follow-up, if you need a sonogram or you need another kind of test,
MRI sometimes, right?
An MRI, it should be covered. That insurance should be required to cover it. It's part of the diagnostic. But we also have a problem that people who've been diagnosed with positive things aren't being covered either. So we're trying to address that in legislation that we are putting forward. Because there's so many different factors here. We have to educate women you need an annual mammogram. We have to educate women, ask for the prescription. I've tried to get this fixed and it just doesn't. But medical systems need to make it easier when you're making the mammogram appointment that this is what you're going to need when you go, so that you've called a doctor's office or they can call, so you don't go and get your mammogram appointment, which can take 3 months to get, and you get there and you can't get it. That's bullshit. So we're trying to address that as well. But breast cancer, I want to say to you, we've done a lot of work. We've raised awareness. We've gotten research done. I'm really proud of it. Last night I went to a News Bash, I went to the first one when it was first done, and it was local media that all helped raise the stories and do the education. But early detection of breast cancer, if you detect breast cancer and it's only in the breast, your chances of survival are 99%. That's how far the numbers come, which is why early detection matters. And we need to get the tests that give you the answer and to be able to do it quickly. So I want to take over your case if that ever happens again. I am the world's expert at yelling at hospitals, doctors,
Awesome.
Institutions, and radiology.
That's what we all need, right?
And I want to tell everybody, don't take the answer. Fight back.
Right. So this would require, all right, we can applaud. That's it.
She's not.
So this would require the insurance companies to then, every insurance company in the country, to cover those supplemental, those diagnostic mammograms and screenings. So, I mean, would that be then a federal mandate, a government mandate? Because I know for Republicans, you're not a real fan of increased government spending or federal mandates.
Well, if you're looking at increased government spending, waiting and purposely waiting to diagnose cancer, it's much better to catch it early on, because if the diagnosis gets caught, the treatment is a lot cheaper. It is a lot less stressful and safer for patients. At the end of the day, you are saving a lot of money by catching it early, as well as saving lives.
You know, Congresswoman Dingell, where are you seeing the resistance to this? Because obviously we're getting applause from the right and the left. I think the two of you seem to be pretty much in agreement. Who's against this? Who is opposing this?
I know, it's certainly
Insurance
bipartisan.
companies?
No, it's certainly bipartisan, and I'm looking at doing some other legislation with Kat Kamek. And I work with a lot of women. Beth's now going to be my new best friend, working on some of this too. But we work on stuff. Right. It's the system, I guess. What would you? I have a lot of health bills sitting at committee that need to move, and too much of this year, quite frankly, has been tied up first in. We use different adjectives for it, but the big blank bill, and now the shutdown. We're not doing work on bills that should be getting done.
But this is the, what is it, fifth time that this has been introduced, right? And it was introduced the first several times when we had a woman speaker. So what's up with that?
So John Dingell taught me. I don't know if many of you have heard of him. He was a very good legislator. Would say, when someone said to him, "You passed the Clean Air Act so fast," and he said, "You son of a bitch! It took 10 years to get it to where it needed to be." And we've got politics in the House. We've got different kind of politics than, there's bipartisan politics. There's budget politics. We just have to get people to see the importance of it. Look, you don't know how hard it was. Long before I came to Congress, I started the National Women's Health Resource Center. I mean, women weren't being included in federally funded studies for everything, for drugs, because we had hormones. But half the population is going to react to things differently. So change comes slow. We made noise, and we got a very deliberate, Bernadine Healy, Republican, led the NIH, started the National Women's Health. We got more women included. I wasn't in Congress when all this was happening either, by the way. Got more women included in studies, but not enough. We're still finding, because drug companies are afraid of impact on things, that you got to keep working.
Sure.
You can't
and
give
it's not
up.
just women, it's women of color, right?
Correct.
I want to touch on this because it's a great question, and this is one of my biggest frustrations. Before I came to Congress, I was a mayor, and being an executive position, it's a lot different because just by sheer force of personality, determination, and just being a bully, you can get a lot done. Okay, you can't do that in Congress. I've tried. I am still trying to figure it out. But people ask, this is a bipartisan bill. This is, it's not a controversial bill. I have people, advocates, lobbyists come into my office all the time. People from my district who have simple requests. Why can't you get this stuff through? And so I started looking at it. how many people here know, on average, how many bills are introduced per session? Just throw it out there. Just give me a number. It's like 10,000. Okay, so think about it. We got 435 people just in Congress alone. That we all think we've got the best bill, the best answer. We want our name on that bill. So everybody's coming up with lots of legislation, and some of our colleagues come up with a lot more than others. But you need to get that put on a calendar to come out of a committee. So you got to make sure, and no chairman is going to put that bill on their committee for a hearing or a markup unless they think that they've got the majority that it's going to pass. So as advocates for a bill, I would ask you, help us do our job, which is whatever the committee of jurisdiction is, make sure that you got everybody on that committee on the bill. That's the first thing, because you got to get it on a markup, which means you got to get it on a calendar, which means you got to get the attention of the chairman to get that on the bill.
What's the committee of jurisdiction?
So this would be under, we are actually already Ways and Means, and probably ENC. Yeah, so ENC and Ways and Means, it would be joint. We already actually got one of our bills out that had to do with seniors and Medicare and having this covered. But, and then the other thing is actually finding time for it to get on the floor, which means having all this excitement and talk about it, because there's so few bills that are introduced, they get out of committee, they get on the floor, they get a vote. And then after we get that, then it has to go to the Senate. And the same thing starts all over again.
So you haven't even really had a chance to start like lobbying your colleagues for this?
Well, I mean,
or no?
Right now I've got like 7 bills that we've introduced in like the last month alone. I mean, you lobby, but there is a lot that's going on, which is why it is so essential. All the advocacy groups that are in this room mean so much, because this happened to me like my first month in office, and then having somebody come to my office and like, oh, here's the bill that we're looking at that could fix this. There's like this aha moment that pops out, and you're like, I'm on this bill. This is something that is very personal to me, but it makes common sense. You know, you talk about costs, you talk about quality of life, you talk about life in general. This could fix that. And so, but it seems like whenever we come to Congress, depending on the number of weeks that we're in session per month, you've got 4 days.
Which has been 0 this month.
But you're typically in session from, on Monday through Thursday or Tuesday to Friday. On fly-in and fly-out days, you don't have committee hearings. So you're talking 2 days a week when you're actually in session to have these conversations. And then I'll tell you, I'm on Ways and Means. We had 7 bills that were marked up last month, and it took 9 hours just for those 7 bills to be marked up. Because every single member can introduce an amendment, and then every person on the committee has 5 minutes for every single amendment. It takes a long time. So this is, when she says it's the system that's set up to move slowly, she's absolutely right. But the best thing that I've found to be able to get legislation moved is having this core advocacy group that knows exactly strategically the members to go after, get their support on it, get the chairman, get it out of committee, have a loud enough voice that it gets on the floor.
So Congresswoman Dingell, are you optimistic? Is there a chance this year?
So I'm sitting here getting an idea with Beth.
Okay.
That if we go and get our women colleagues and we go and meet with the chair and ranking of your committee and my committee, but we get all the women from all of our committees, tell them we got to move this. I wish we had been in, because then we could have said, let's get it done for Breast Cancer Awareness Month. But we'll find another breast cancer date, give them a time deadline, and then get it on the floor to celebrate that date and have something pass the floor that would be.
I mean, and that's fine.
It may or may not work.
Like I think there's lots of bills that I would advocate for, but I know a lot of brothers, a lot of husbands, a lot of fathers. This is not just a female issue.
No, it's not.
This is not just a woman's issue. And I know my son, my dad. My dad's an OBGYN, and he was the first call that I made. And I'm like, hey, can you write me the prescription so I can go ahead and get my mammogram done? And he tried, and they wouldn't let him because we were related. So,
something else, just as an aside, men get breast cancer too. And actually, it's right now the largest killer of African American men in cancer. I was at something at home, and I've been sworn that I may never. This is something that we need to. There is a real stigma if a man has breast cancer. They don't want people to know it. They don't want. I have been sworn to forever. I may never mention who has it, so I won't. But then this other it was an elected official in Michigan was hosting a breast cancer event, and I brought up that men get it too. And he said, Debbie, don't ever say that again. We don't want to talk about men. That's it. We got to get rid of that stigma. We had it 30 years ago. Men need to get rid of the stigma too, because it can kill if it's not treated. Early detection saves lives.
So, Congresswoman Dingell, what I was wondering, we're here talking about cancer. You're also chair of the House Cancer Caucus. Do you have other priorities when it comes to advancing cancer care you want to touch on today?
I care very much. Lisa McGovern's here, who is organizes all the spouses for Prevent Cancer, and we've worked on a lot of different issues, and there are things. It's the education process, wouldn't you say, Lisa? For so many different. There's a Prevent Cancer organization, a Prevent Cancer Caucus, and we've all been hit by cancer in so many ways. Had a little boy die of a brain tumor. I've had family die of different cancers, and I think there's been a war on cancer for decades in this country, but too many people don't know the issues that can help them, the food that they eat, the environmental factors, the sun exposure. I could go through all the lists. So, we are all human beings. And in the Congress, there's far more that connects us than divides us. And bringing people together to work on the issues that matter to people in their districts and in their home, shining a light, trying to find the answers, trying to develop policy that helps them is something we work very hard on.
And Congresswoman Van Dyne, if this passed in your district there and across Texas, there are a lot of rural areas, there are a lot of imaging deserts. Looking ahead, do you have thoughts for ways that those people in those underserved areas could get access to this imaging,
first of all,
diagnostic, cost-free diagnostic?
Let's start using technology. There's a group, every year they have this healthcare technology fair. Have you seen it? They've got technology now that basically fits into a tiny little box that you can actually take it out to rural areas. I think also expanding on telehealth. If there was a silver lining in COVID, telehealth was it. And I can't tell you just from, I was a single mom of two young kids and working full time and trying to figure out times to be able to go to the doctor. Sometimes I just wanted to be able to make a phone call. But, once you have the image, trying to get back in, it's the follow-up so often that's so important and is missed because people just can't schedule it. So having more opportunities for telehealth and then having that covered under insurance as well. I think those are all avenues to be able to explore that would definitely help in the rural healthcare.
So I must admit, I forgot to look at the schedule. When are we due to wrap up, guys? Give me my time.
3 minutes.
3 minutes, thank you. I didn't know where my timer was. Let's talk also about an additional measure that you have been working on, the Patient Access to Higher Quality Healthcare Act.
Yes.
That's important to you. So does that factor into this discussion?
Well, absolutely. Again, it's looking at physicians, and we want them to be able to have hospitals as well. I don't understand why that was prevented. My first job out of college was working for a healthcare company. It was a physician practice management company that owned a management services organization. And there's a lot of letters and a lot of words in there. But the idea was to allow patients and physicians to have that relationship so that all the back office could be handled by folks who weren't touching patients. And the idea was to put together a group of physicians that could then go and have direct, could contract directly with businesses and bypass the insurance companies. Because what we found is the more money that goes into the healthcare system, the more money that the government is putting into the healthcare system, the more costly it is, less access, and quite frankly, less quality. We're seeing the same thing in education too, by the way. The more you pump into it, basically what we're doing is writing a blank check to the insurance companies. And having health care insurance is not the same thing as having health care. So we're trying to allow people who've got more education, more experience, actually touch and see and feel the patient to have more decision-making in their care. And so allowing physicians to actually own hospitals, I think is really important. And this is a bill that I'm working on with Henry Cuellar. Again, it's a bipartisan bill, a common sense bill. And hopefully we'll be able to see a lot more of these healthcare bills that are common sense that will actually fix the problem than just kind of talk about it and throw more money into a system. Like, we're throwing more money into a program that we know doesn't work is not fixing it. It's extending, it's that Band-Aid, and it's throwing good money after bad.
So to fix these problems, we have to have action. To have action, you have to be in session. So are either of you optimistic? We're at day 22 of the federal shutdown. What are your thoughts? Any compromise in the works?
We have had such a nice bipartisan conversation right now. You don't look. I am in DC because I've got a ton of meetings. This morning was particularly important to me. I wanted to make sure that I came, shared my story, and got to hear what the audience had to say. I was not bedazzled like you are. I mean, good Lord. I'm looking at you. Look fantastic, by the way, this morning. This is the best. I don't have pink. This is the closest I could get. But look, we have a lot of work to do. I would love to get the government open. I don't like being held hostage like this. I think there's a lot of legislation that we do have to pass. House has done its job. We're waiting right now for the Senate, to be able to pass a funding bill. I think it's ridiculous that we're not supporting and trying to figure out ways to be able to pay staff that's working. I was part of the Trump administration, the first Trump administration. I worked for Dr. Ben Carson, and I lived through the longest shutdown in our nation's history for 35 days. I was an essential worker. I was actually the only person in the office, and it's not fun, especially those folks who are working paycheck to paycheck. So. We passed, we passed a funding mechanism out of the House, but I am really looking forward to working on these bills and getting them on the floor.
Congresswoman Dingell.
I like the bipartisan discussion we've had of how we are working. Look, people are hurting. Yesterday, my TSA workers in Detroit, the morale difference in a week, and we've started to figure out ways to get them food. And I've been meeting with government workers all week, quite frankly, and people are hurting and scared and don't have money for gas. A mother told me yesterday at the airport she had to choose between gasoline in her car and milk for her child. So these are real life things. But I will say, I hope we can come to agreement. The healthcare exchange opens on November 1. We are seeing horrifically high increases. A 60-year-old couple in my district that make a combined $82,000 have a premium increase of $11,250, 164% if we don't extend this credit. I'm somebody, we will have good discussions about all this. We get where we are. I believe if you're sick in this country, you should be able to go to the doctor when you need to go to the doctor. Get the tests and the treatment you need, and to be able to afford your medicine. And I am going to work towards that every single day for whoever you are.
Okay, I just want to add real fast on that. When we talk about the money that's coming into the system and the premiums that are going up, the people who are increasing the premium are the insurance companies. And the insurance companies have experienced 230% increase in profits. 230% increase in profits as those families that you're talking about have seen their premiums increase by 86%. And by the way, these same insurance companies that are experiencing 230% profits are also denying a third of all claims. If we want to make sure that people have access to health care, that's where we need to start.
All right. Congresswoman Van Dyne, Congresswoman Dingell, thank you so much for joining us. Thanks for the great conversation. Really appreciate it.
It is now time for the sponsor portion of today's program. On behalf of the Alliance for Breast Cancer Policy, please welcome Katie Mazouk, Chief Patient Experience Officer at Novartis US, to talk to Kathleen.
Feel like a game show host. Come on down.
Yeah, great to be here. Good morning, everybody.
So, Katie, such a great discussion, right?
Exactly.
So, as we just heard, breast cancer screening and treatment, they really do continue to be a challenge in our country for women, for their doctors. You have been a leader in this space for more than a decade. And what are your thoughts on the state of breast cancer in the United States today?
Yeah, it's a great question, and it's one of the things that I have two big emotions around. One, I'm really incredibly proud of the innovation that we've brought forward in breast cancer treatment. As we shared earlier, right, if your breast cancer is detected early, you have a 99% survival rate. That is amazing. I'm incredibly proud of the innovation that's brought us here. I like to tell my daughters about that, my mothers, my neighbors. That's something that really makes me really proud. But we've also talked about the other side about this, because that takes early detection to get there. So we still know that only 1 in 2 women that are eligible for their annual mammogram get their annual mammogram. And that's a huge barrier in early detection. So it's a very two-sided story here, where we've got incredible innovation, incredible treatments, great survival rates, but access remains low in early detection and screening. And that's why Novartis and Susan G. Komen, we were the initial partners founding the Alliance for Breast Cancer Policy, as we think it's really important to tackle this. And now I was talking this morning, I think we've got over, with Molly, I think we've got over 30 partners in this initiative to move this work forward.
So why are these conversations about breast health, breast cancer, why are they so hard for women to have?
Yeah, we were deeply curious about this as well. So we created the Breast Health and Experience Index, where we've talked to over 3,000 women, 1,000 of those women with breast cancer, to talk about what are these complex emotions that we have around our breasts and breast health. And as Congresswoman Dingell said, there has been a lot of stigma, but actually a lot of stigma and shame and silence still exist with women today. So out of these 3,000 women, 50% said society's sexualization of breasts prevents them from talking openly about breast health. Over 50% said they feel ashamed having conversations about their breasts and breast health. And while 80% of women said they feel educated and informed about breast health, that's not really translating into action today. So again, the bigger picture question is not just about awareness and education, it's how do we bring action to life related to breast health?
So are those feelings, is that what's behind that figure you mentioned earlier, that only 1 in 2 get their screening?
That's definitely part of it. The other part that was also talked about by Congresswoman Van Duyn and Congresswoman Dingell is around the financial side of this as well. So while there are access to mammograms, only 1 in 2 women are showing up to get their annual mammogram, but additional diagnostics and testing is required by 1 in 10 women. Dense breasts require MRIs, additional scans, ultrasounds. And what we found is that for those additional diagnostics, patients with commercial insurance, 70% of those patients face out-of-pocket costs. And out of those 1 in 10 women that have to go get the additional tests, the majority are not showing up for their additional tests. They already
So it's all about the money.
It's all about the money, and it's about the complex emotions as well that are even preventing women from getting their annual mammogram. So there's a bunch of different things in play, but let me give you another point about the money, is that we know, we said this earlier, if you detect earlier, you've got better outcomes, but it also saves the healthcare system. So earlier detection, earlier treatment with women, with innovative treatments that we have, advanced therapies, less invasive therapies that lead to higher quality of life, saves the healthcare system on average about $14,000 per patient, but over $2 billion over the lifetime of breast cancer patients. So again, a common sense issue leads to better outcomes, but also saves the US healthcare system money.
So you're chief patient experience officer
Yes.
at Novartis. So you work with patients on their treatment journey.
Yeah.
So when we're talking about breast cancer, what are the hurdles that patient population faces?
Yeah, we've talked about several of them. We think very strongly that while access to innovative therapies is critically important, we're very proud as an innovative medicines company about continuing to innovate with better treatments, better efficacy, less side effects. The journey begins before you're ready for treatment. So we know patients are facing barriers, whether it's stigma, awareness, access, and we feel very strongly about the ABCD Act as an important move forward that goes across as far as giving patients better access to detection and advanced detection based on their annual mammogram. And then I also have the privilege and the responsibility as patients are prescribed their therapies to help them seamlessly start on their therapies, navigating their insurance, providing financial support, pharmacy logistics, adherence questions, any support. So the journey's long, but we believe it's our responsibility to look end to end across this because it's not okay to have innovative therapies and 99% survival rate, but not also be able to get to early detection.
So Novartis makes drugs for early and metastatic breast cancer. But you're here this morning really emphasizing the importance of screening. So why is a drug maker so invested in screening, in early detection?
Yeah. We believe it's our responsibility to look at health holistically. Again, it doesn't matter if you've got life-saving treatments. If patients can't get diagnosed, what does that matter at the end of the day if we're continuing to work from an innovation perspective? So we see our job, we have two responsibilities. We've got to look really broadly in the healthcare ecosystem. We're deeply invested and focused on women's health and breast cancer, and it's our responsibility to take a look at this broader ecosystem and hear about the journeys that our amazing advocacy partners and real women with real experiences have to say, how do we break down these barriers to make sure that early detection and screening are the standard for everybody, not just a privilege for few. So that's our first part of our responsibility. Mm-hmm. The second part is around continuing to innovate in this space. We believe strongly in research, innovation, continuing to say that the therapies of today, let's look for the therapies of tomorrow, that we have incredible progress, but there's still more to be done. So we view our responsibility as twofold, and we're very excited to be part of the Alliance for Breast Cancer Policy and moving these important issues forward.
Kind of one thing I picked up from the lawmakers, I think you all did as well, is we need to draw attention to this issue. So do we all need to get more creative? I mean, Novartis kind of went out on a limb, shall we say, during the Super Bowl, the infamous ad. How did that work, and do we need more of that?
Yeah, I think that's absolutely part of the solution. So if you haven't seen the Super Bowl ad, go and watch it.
You gotta check it out.
It's an amazing ad, but it was based on a really important insight. And the insight was that breasts have so much attention, but are so ignored in society. And that was the key insight that we worked with women with lived experience with breast cancer, our advocacy partners, such an aha moment, because there's great awareness about breasts.
They get a lot of attention.
Great attention. That's not necessarily the fundamental issue. But I think it was very surprising for people to hear about only 1 in 2 women get their annual mammograms that are eligible, get their screening. And what we believe, again, awareness is not the only item, but it was an important spark of a conversation. It helped families start to talk about it. Are you getting your mammogram, Mom? Are you getting your mammogram? Daughter, friend, talk about it. Reminders, a call to action to start the conversation and continue to reduce stigma, raise awareness, and also expose the other issues that are at play as early detection requires more than just your annual mammogram. the hurdles that people are faced in the system. So we think it's an important part of the conversation.
And you set up a website too, didn't
Yes.
you? I mean, talk about that, like, for people to send reminders
Yes.
to the women they love.
Yeah, exactly.
screened.
Part of our Your Attention Please campaign. So in addition to our commercial, we also had a call to action where women, men, family members could sign up for annual reminders, but also send reminders to somebody else. And we loved that conversation and what it sparked, because it is holistic. It's a full action that we can be taking, and we saw incredible traction on that. The momentum continues today, as we've had a lot of activation around that, surrounded by our partners. So it's part of it. We're really proud of that. But of course, it's based on a very deep and true insight of so much attention, but so ignored. And that's our responsibility today, to how do we change that? And we're really proud of the ABCD Act, the Alliance for Breast Cancer Policy, and these broader movements where we can align across research, policy, and advocacy to make sure that breast cancer early detection and screening is a standard for everyone, not just a privilege for few.
Well, Katie Mazouk, thank you so much for joining me, and thank you for Novartis's attention to this issue.
Thank you.
Thanks again to Alliance for Breast Cancer Policy for their support of today's program. Now joining Kathleen on stage, please welcome our panel of experts to talk about breast cancer screening and policy. Ricky Fairley, co-founder and CEO of Touch, the Black Breast Cancer Alliance; Molly Guthrie, Vice President of Policy and Advocacy at Susan G. Komen; Joanne Pushkin, Executive Director at Dense Breast Info Incorporated; and Dr. Christine Edmonds, Associate Professor of Radiology at the University of Pennsylvania Health System. Welcome.
Welcome, ladies. Thank you. So I want everyone to know what you guys are working on and know a little bit about you. So I was wondering if we can go down the line and have each one of you share what you consider as a major gap when it comes to breast cancer screening in the United States and how your organization is tackling it. So Ricky, would you start us off?
Of course I had to be first. Thank you. So happy to be here. You know, black breast cancer is actually a different disease. We now have science that validates that a black breast cancer cell looks different from a white one. And we're tackling that from all aspects. We also know that black women under the age of 35 get breast cancer at twice the rate of white women and die at 3 times the rate. So a 40-age screening age is too late for us. So we're really trying to understand, you know, how to look at it differently. We also know that black women have about 8% have health insurance, but 45% are underinsured. So when it comes to that diagnostic screening after a not so great mammogram, it's $2,000 to get an MRI, and I walk away from that. We're also getting screened later, and I think that the Congresswoman talked about her experience about waiting 3 months to get a mammogram. That's very, very typical, especially if you're under 40. It's really hard for them to get a mammogram. So we're really trying to talk about what's different. We also know we had talked about stigma about breast cancer. The Ad Council did a study a few years ago, and we found that 92% of black women are aware of breast cancer. Everybody knows about it. 25% of black women actually talk about it with their friends and family, but only 17% act on the risk.
Wow.
So those numbers are pretty devastating if you think about people just aren't talking about it, aren't aware of it. And a lot of it's just lack of understanding and lack of knowledge about how important it is to check your breast and get screened.
So what is your group doing specifically?
We are doing,
on those
we
issues?
actually have an outreach to young women. So we have a web series that we do every month called Pink Table Talk, and we talk to women who are healthy about breast health. We talk about helping them understand their risks, understanding her story, talking to their families about their health history, and also making breast health an act of self-care. And we educate about the importance of breast health. We have an HBCU internship program. So we hire about 10 or 15 interns every semester from HBCUs. We pay them to do our TikTok. God forbid, I don't know what's on the TikTok. I'm not too old for TikTok, but we engage them to talk about breast health with their peers and with their families. So it's really important to hit them at a young age to understand what they're up against, what their risks are, and that breast health should be an act of self-care.
Very smart. Yeah, especially addressing young women, because that's the group where we're seeing the rate of breast cancer go up the
Yes.
most quickly.
We also have a nurse navigation program where we have 24/7 navigators. Our navigators are all Black women. They're all breast cancer survivors, so they can talk the talk because they've walked the walk. So we have them counsel families, counsel patients, counsel people, and we really try to engage them, hopefully before the patients need them. People
Molly,
need them.
you're with Susan G. Komen. I mean, I know you're doing so much, but what is the gap you're trying to fill when it comes to screening?
So at Susan G. Komen, more broadly, one thing that makes us unique is that we really go after these issues with a 360-degree approach. So I wear the policy and advocacy hat, and so we, obviously focus on legislative and regulatory change, but more broadly, we know it's important to invest in research. And so, we invest in research at Susan G. Komen. We also, similar to Ricky, provide immediate care and assistance to patients going through this experience, whether that be someone calling our helpline to just figure out what to do, or maybe they need financial assistance to be able to cover the cost of their screening. And then again, all of that is really underpinned by education and our policy work. In the policy space, we have an ever-growing portfolio of issues that we're having to address, unfortunately, that our community is facing. But looking specifically at screening, really the whole reason we're here today, right? We know that all people should have access and equitable access to affordable and high-quality screening, healthcare more broadly for sure, but specifically on screening. So in addition to the ABCD Act, we also spend a lot of time advocating for the National Breast and Cervical Cancer Early Detection Program, which is a fantastic program housed out of the CDC that's been in existence for 30 plus years now. And to Ricky's point, we know that there was a large uninsured population, underinsured population, and unfortunately that population is likely to expand and grow. And so this program provides, from the beginning all the way to, screening, diagnostics, biopsies. If you're diagnosed, then you can be navigated into treatment. And so working really across the spectrum, regardless of your insurance type or if you're uninsured, to really get us to a place where there is equity and that people can get the screening they need, when they need it, where they need it, and not have to face administrative and financial barriers to that.
Now, Joanne, I know your focus is dense breasts. That's it. Okay. So what are you doing?
So 40% of women have dense breasts. For those women, they are at increased risk of developing breast cancer and of having that cancer missed on a mammogram. In women with the densest breasts, a mammogram will miss about 40% of cancers present. That's almost a coin toss. They're also at an elevated risk of developing breast cancer. So I and fellow advocates fought for density-informed laws state by state, and finally in September of 2024, it became an FDA requirement that all women after their mammogram be informed whether their breasts are dense or not dense. So armed with that information, that certainly helps the screening experience for a woman because now she knows she has dense breasts. We would like everyone to ask them the question, is my mammogram enough? Because that's the question that should follow. And if the answer is, oh, dear, you need more screening, that screening should be covered. Because for women with dense breasts, if 40% of cancers at least are missed, that's incomplete screening. It's incomplete screening. Mammograms are not as effective for all women. So for women with dense breasts, it's a compromise tool. And to complete that screening cycle, they need more screening, and they should be able to afford it. And so we're supporting the ABCD Act and the Find It Early Act. Now that it's federal requirement that women be told they have dense breasts, what the complement to that now, of course, is insurance that they get the screening they are now told they probably need.
So, Christine, you are the doctor on the panel. So tell us about what you are tackling in this area.
Sure. So I am faculty breast radiologist, and I'm thinking, hearing everyone else mentioning what they're talking to, I don't even know where to begin. There are so many different aspects that we are working on, but I'm going to highlight, for the sake of brevity, 2 key ones. 1, time to diagnosis. That is key. As we heard from our Congress members and people on this panel already, it makes a huge difference. So whether we are decreasing time to diagnosis and subsequently time to treatment by getting women in through screening or diagnostic imaging, i.e. they feel a lump, they have a symptom like that, then they need subsequent imaging, then they need a biopsy. So as you can imagine, time accumulates at each of those steps. We have good data that with those increases, what we might think is a relatively small increase in time, so up to 60 days to start your treatment, if that's frequently surgery up front, that's not very long. So if from presentation to surgery, you go beyond 60 days, not very long, when you take into account all the other things that have to happen, the biopsy, extra appointments, et cetera, you are already having increased mortality when you hit that 60-day mark. Beyond that, additional 30-day intervals, same thing. So time is of the essence, both for screening and diagnostic. So we're focusing on that. Within that, as you can imagine, we have tremendous disparities. My colleague here mentioned some of them. We have racial, ethnic, socioeconomic disparities. We have to work to address those. Second key area, we need better biomarkers to figure out who needs what screening and when.
Can you explain to our audience
Absolutely.
what a biomarker is?
Yep, so it's sort of a big collective term. It is some sort of marker of biology. And it can be a blood marker. Some of you have probably heard about blood tests that are looking for things like protein or DNA, things that can show if you have cancer now, but can also show if you might get cancer or at heightened risk of cancer in the future. As a radiologist, I'm also interested in imaging biomarkers. Density is the example that most of us are familiar with. So not only does having increased density elevate your risk of developing breast cancer, it of course makes the mammogram less sensitive, which Joanne just mentioned to us. So imaging biomarkers, density, and ones that go beyond, things that look at enhancement of the fibroglandular tissue in the breast. So looking at the biomarkers so that we can figure out who needs regular screening, who needs supplemental or high-risk screening, i.e. things like MRI. Not just who needs it, but when do they need it, right? All of these resources are limited, cost, access, et cetera. So not only are you at risk, but when are you at high risk in your life? Is it this 5 years or is it 20 years down the road? So that we can better deliver the care to the people who need it while making the care more equitable, right? Some of the biomarkers, for example, density that we use right now, aren't particularly equitable. That biomarker is more helpful in white women, for example, than it is in black women. So putting that all together, we are doing research at my own institution to develop those biomarkers, test them, and simultaneously to make the care that we do have, screening, diagnostic care, et cetera, more accessible to our communities, targeting specific communities in and around Philadelphia that are underserved currently, our Black communities, our Latina, Hispanic communities, through specific pilot interventions with the ultimate goal of getting the time to diagnosis down.
I have to follow up on that. So why is breast density not a good biomarker for women of color?
That's a great question. And I wouldn't say it's not good. We certainly don't want to ignore it. It's not as good for white women. Part of that...
For black women?
Excuse me, for black women, thank you. Part of the reason that it is not as good for predicting risk in black women is that it is at least tied to BMI and body size. So when we talk about breast density, the way that we currently evaluate it as the radiologist is usually just a quick gestalt qualitative assessment. And it's a ratio of the fibroglandular tissue. That's actually the breast tissue, the cells where the cancer develops and then spreads. It's a ratio of that tissue, the fibroglandular tissue, to the fatty tissue. And so when we use a ratio like that, you can imagine if body habitus is larger, the body overall has more fat, then that proportion of dense tissue is going to look qualitatively lower compared to the fatty tissue in the breast. And so unfortunately, if we use those qualitative assessments, black women are less likely to be candidates for supplemental screening if we rely on those qualitative density assessments. So unfortunately, we've already heard black women get breast cancer at younger ages, present at higher stages, and have 40% higher mortality. So the very population that you might think, wow, they're gonna need some extra screening here, are unfortunately a little bit less eligible if we're using simply that density biomarker.
Well, Ricky, I'd like to go to you. I'm sure you have a lot to chime in on with that, because as you touched on earlier, I mean, breast cancer for Black women, it's almost a different disease.
It is.
Right?
It is.
And share your experience, if you would, because we do have 2 breast cancer survivors on the panel, you and Joanne.
Black women are 3 times more likely to get triple-negative breast cancer.
That's what you had.
Which is what I had, which is the most aggressive breast cancer. It's the only breast cancer that does not have a drug to prevent recurrence. And it recurs very readily. Mine came back after a year. So I was diagnosed with stage 3A. And actually, I think the number is Black women are 3 times more likely to get stage 3 or 4 breast cancer, which is what I got.
I have to ask you, why is there no drug to prevent recurrence for this?
We don't have one yet. So you may have heard of taking tamoxifen for 5 or 10 years or whatever. We don't have a drug. It's the only breast cancer that doesn't have it. And it's the breast cancer that doesn't have the other biomarkers that most breast cancers have. I was diagnosed at stage 3A. I had a double mastectomy. Yes, these are fake boobs. I did standard of care chemo. I did 6 rounds of radiation, 6 weeks of radiation.
And what year was this?
This was in 2011.
2011.
So we really had nothing for triple negative back then. Now we have 2 targeted medications, but I was told I had no evidence of disease. After 8 months of treatment, come back in a couple months for a scan. I came back exactly a year to the day of my first diagnosis, almost, and I had 5 spots on my chest wall. My doctor said, okay, we have nothing for you. You know, you need to get your affairs in order. You probably have 2 years to live. I said, I can't really die right now. I have
no time for this.
I have a daughter at Dartmouth. I have to pay tuition. I got to get my kids through school. She was a sophomore, so I had to figure out what to do. And I went and advocated for myself. I went to Dr. Google. I did all the things. I found a doctor who put me on a clinical trial for another drug where they were testing for triple negative at the time. I did a lot more chemo, and I didn't die. And a month ago, I celebrated 14 years.
Woo. All right.
So this is my God job. This is my God job. I know God left me here to do this work and talk to Black women. But we also know that Black women are 58% more likely to get de novo breast cancer, meaning it's metastatic from the get-go. And we don't really know why. I mean, our breast cancer is different. We now know the cells look different. So we have a lot to do to understand, you know, how to help Black women, and they really need screening earlier, and we really need diagnostic screening earlier and more readily. So we have to work on that.
Well, and one thing I would add, just adding to these 2 points, is specifically looking at the ABCD Act. We refer back to NCCN guidelines. And so those guidelines...
NCCN, explain to the audience who might not know.
They are a guideline issuing body that follows the science, the research, the data. And so they stratify out by risk. So density is part of it, but there's also, genetic mutations and family history and other components. And so it expands the eligibility, right? It's not limited to say that you have to be 40 or older, or, it's only for follow-up, especially for that supplemental imaging. And so that's what we've found through the many years of our work at the state level, to find to be the most expansive for being reflective of what we know about risk, to ensure that people are getting the imaging when they need it, but also the type of imaging and the frequency that they require. We are still losing far too many women and men to this disease, but we know so much more about it now that we can, get people, if we can create equity and access, we can get people the right screening, the right diagnostics to get them to an earlier diagnosis for a lot of the population.
But that guideline is still for age 40. And that's too old for Black women. We're getting it younger. Black women under 30 have a 50% higher mortality rate of breast cancer than white women. And so we have to change how we think about screening, and not only the diagnostic screening, but the age is so important. And that's a whole nother act that we're trying to...
And that's going to have to come from the FDA, right?
Yeah.
For it to be covered.
But just to clarify, the NCCN guidelines aren't limited to only 40.
That's true. And
there's a whole other governing body that
it does that.
We won't open that can of worms.
I know. No, but what we encourage is for Black women, and what doctors recommend is for them to get a risk assessment at age 25. Wow. And a risk assessment.
Is that covered by insurance?
It's usually, it depends. It depends on your insurance. I mean, and most of the time you can go to your gynecologist and get a risk assessment. and they'll refer you to a breast surgeon or something. But it requires insurance. It requires, and probably good insurance to be able to do that. But we know our disease is different because there's a study done by Emory, Lauren McCullough. She's an epidemiologist at Emory, and she did a study a few years ago, and she found that Black women who have equivalent insurance to white women still have a 60% higher mortality rate of breast cancer than white women. Black women who live in a high socioeconomic neighborhood still have a 126% higher mortality rate than the white women in the same neighborhood. So that's why we know the science is different for us, and we need to consider all those things.
Yeah. Sounds like we need a lot more research
Yes.
into that. It's so fascinating to me to see women who are survivors like you, like Joanne, who you are driving so much action in this area. And Joanne, I wanted to talk to you. You helped push the FDA to finally put out these requirements that, radiologists say, inform women, you have dense breasts, and this is how dense, and this is what that means. How did it feel to have accomplished something like that? And what are some remaining misconceptions and misunderstandings about breast density that you're working on today to change?
I think when we got word that the FDA agreed that, yes, we're going to come out with the guidelines, and they came out with them, I remember getting the news, and I just kind of sat down heavily in my chair and thought, excuse me, Jesus Christ, I'm glad it's over. I just thought this was going to, this just took so long to get this done, and there were so many women in so many states fighting, frankly, while they were dying, to be sure, getting chemo, getting an infusion, and typing on their other hand to lobby their state legislators for women to be told this information. Why should we have fought so hard to be told this information? Why was that a secret? Why wasn't I told I had dense breasts? Why, when I was finally diagnosed, I was going for mammograms, doing everything right, healthy girl, ate right, and one day I feel a lump, but it had only been 8 weeks since my normal mammogram, and I really wasn't worried, but they tell you call your doctor. Of course I did. And I went right in, and he palpated the lump also, sent me on for a diagnostic mammogram and an ultrasound. And I go for the mammogram, and the day the lump is so big, I can feel it. I've got no better background. I can feel the lump. It doesn't show up on the mammogram. And the aide comes back in the room and says, the mammogram is clear. And I was in a large facility with multiple waiting rooms. And I said to the girl, oh, honey, I think you came back into the wrong room. I'm the lady with the lump so big I can feel it. And she says to me, oh, honey, you've got dense breasts. We're never going to find that. And I remember sitting back, and my thought then involved the F word.
Wow.
And then, but then I go for the ultrasound, and there it is, clear as a bell. And so, of course, my question is, but so now why wasn't I getting that ultrasound every year? And when I check my medical records, and by the way, by size and stage, the cancer was estimated to have been growing 3 to 5 years in my breast, undetected, every single one of them by mammography. And every one of those 3 to 5 years, I get a letter after my mammogram telling me my mammogram is normal. Women with dense breasts are not aware that getting a letter that says your mammogram is normal is not a reliable indication that cancer isn't present. Right. So when I get the reports then, I was so curious about this dense breast. What is this term that this person is using? I mean, every single one of those years, the report that was sent from my breast imager to my referring doctor mentioned my extremely dense breasts. So my doctor knew I had dense breasts. My radiologist knew I had dense breasts. Who didn't know? Me, the patient.
Let's talk again about some misunderstandings or, like, for instance, women who have dense breasts, they change over time. Like, so when you hit menopause, then you might not have dense breasts. I mean, just help us with misconceptions.
The younger you are, the more likely it is that your breasts will be dense, because it is a function of hormones somewhat. And generally, they get less dense as you get older. My mother is 88 years old with dense breasts. Wow. So it's not that it's a guarantee that it will decrease.
Interesting.
I believe the number is 60% of Black women have dense breasts. So for us, we have dense breasts plus all the other stuff that's going on. So, and we don't even know. We're the ones who aren't getting mammograms, are just really at risk.
Christine, I wanted to talk with you a little bit about MRIs, because I understand that you have studied the optimization of breast MRI screening and diagnosis. So what have you found, and how can MRIs be used in the future to detect more disease?
Sure. So MRI, for those less familiar with it, that's magnetic resonance imaging. And when we are talking about it for breast cancer, we're talking about with contrast enhancement. So a type of dye that is injected through the vein before the MRI. One nice thing about MRI is there's no radiation. So while most medical imaging, or a lot of medical imaging, has radiation. We do need to keep in mind it's very, very low dose, generally quite safe. MRI has none, so that's nice. MRI is highly accurate for diagnosing breast cancer. In particular, it has very, very high sensitivity, which means that if there is breast cancer in the breast, even if it's small or early stage, such as ductal carcinoma in situ, that's when the cancer cells are still in the duct, or a very small tumor, i.e. when we want to diagnose it before it has spread to the lymph nodes or beyond, MRI has a high sensitivity for that. Now, we all know no tests are perfect, right? So what are the downsides of MRI? I've just told you it finds cancers really well. Well, it's expensive. It's very expensive. Currently, there are many issues with insurance coverage of MRI. So even if your insurance company says they cover MRI, there is frequently cost sharing, meaning a high out-of-pocket cost for the patient. And that can be the case for screening. So what I mean by screening is somebody who has no signs or symptoms of breast cancer. So why would they be getting an MRI? Well, currently, that would be because they are at higher risk than the average person. So generally, higher than 20% lifetime risk. Lots of ways to calculate that, lots of online mathematical models to calculate that. Those patients should be getting screened with breast MRI every year. Probably at least a subset of patients who have dense breasts should also be getting screened with breast MRI because, as we've already heard, mammogram is not perfect in anyone, but it is more limited in patients with dense breasts.
So how much better is an MRI than a sonogram, which often women with dense breasts are sent to get? Because I have dense breasts, and they would tell me, oh, now you need to go get a sonogram.
Yep. So MRI, unfortunately, because it is more expensive and a bit less accessible than ultrasound, is more accurate than ultrasound. Okay. Also, part of the problem with ultrasound, so when we think about screening mammography should diagnose, on average, about 5 cancers per 1,000 screened. If we do supplemental ultrasound screening, so an ultrasound of the entirety of both breasts.
After the mammogram.
Correct. That's going to pick up a couple, 2 to 3 extra cancers. You think about that, that's pretty good. But there are some heavy costs to that, which is why it falls a bit lower on the list as far as what's recommended for supplemental screening by some groups, NCCN, as we've already heard about, ACR, American College of Radiology, and the Society of Breast Imaging. What are those costs? Well, it finds a whole lot of things that we cannot tell if they are cancers, resulting in a lot of follow-up and unnecessary biopsies. So what we call false positives. So that's the challenge with ultrasound. So no test is perfect. MRI also, of course, has false positives. It's expensive. So those are the 2 main strategies that we use, at least for supplemental screening. So I'm talking about women with dense breasts who need something extra. If you are at high risk, and that's because of genetics or family history, strong family history in particular, there really isn't a question. MRI is what you want for your high-risk screening, not ultrasound. So that's fairly clear.
But no cancer should fall through the gap.
Right.
It's not acceptable.
Well, for Black women in particular, when we talk about the screening gaps, what are you seeing, and how do we close those gaps? Are they greater than ever for women of color?
Well, I think it's just knowledge and understanding what cancer, what your family risks are, what your family history is, and access to care. Access to screening. Can you afford it?
I mean, are doctors less likely to recommend that MRI, that ultrasound?
Yes. Yes, they are.
So you have to advocate.
You have to fight for yourself. You have to advocate for it. My daughter, she's 39. When she was 39. So I don't have any genetic mutations, but I have a family history. My mom had breast cancer, and my mom's aunt had breast cancer. She died at age 42. And so my daughter at 39, she had 3 babies. She nursed her baby. She's okay. I'm done with my breasts. And so she wanted to get a mastectomy. So we had to go through all the screening to make that happen. And we had to pull a lot of strings and talk to a lot of people and do a lot of begging to even get her a mammogram at age 38.
What did they find?
So they found nothing on the mammogram. Then she had a sonogram. They found a suspicion on the sonogram. Then she had an MRI, and they found a suspicion. By that time, she had already scheduled her mastectomy, and so she was able to get it. Probably had she not done that, she would have gotten a biopsy. So we don't think she had cancer. It was probably a low likelihood, but she did have an 81% risk of getting breast cancer. So she had a prophylactic mastectomy at age
That's
39.
a huge decision.
But I think she was educated enough because of the work that we do to be able to do that and make that choice for herself. And everybody should have an opportunity to make a choice if they have a family history, if they have the BRCA gene or genetic mutation, to do that. And it shouldn't be a financial issue.
You know, Molly, speaking of financial issues, that's what the ABCD Act is all
Yes.
about, removing that so that women can get these additional screenings. And I know Susan G. Komen, in addition to working on the national level for the ABCD Act, you've taken the fight to the states.
Yes.
Talk to us about that and how successful you've been there.
Yes. Before I do that,
Okay.
I know in the first conversation, the infamous M word came up of mandate. So I do want to provide just a little bit of clarity there, because
right
the
ahead.
vast majority of insurers already cover the screening, right? They are following NCCN guidelines as far as
Yes.
coverage. The issue, to your point, is that financial component. And so while it's covered, it comes at significant cost to the patient. And so we frame it as a really cost adjustment issue rather than a new mandate for coverage.
Thank you for clarifying.
Which I share, because I think that's part of the reason that we've been so successful at the state level. So as we heard, things tend to move slowly here in Washington, D.C. And so when we started hearing from our community, goodness, probably a decade ago now, about confusion post-ACA, right? There was all this promotion that screening is covered, no one's going to ever have to pay out of pocket, you can get an earlier diagnosis. People were confused why they then were still being told, well, you have to pay $50, a couple $100, $1,000 out of pocket to get this imaging that you need. And so, come to find out, that was that division between regular screening or supplemental screening and diagnostic imaging. So we dipped our toe in the policy solutions at the state level first to see what would work, what sort of resistance we would come up against. And so did that for a couple of years before first introducing the ABCD Act back in 2019, I believe. So we started in 2017, 2018. Well, there's still a few states pending this year, so we might see that number go up. But as of today, there are 30 states that we believe provide the coverage at no cost and for the number of screenings that might be required. So really comprehensive coverage in 30 states across the country. And those are big states, small states,
Red states,
blue states, rural, urban, really the whole continuum. We're seeing this real momentum at the state level, which is huge, right? To date,
Huge. That's huge.
we've removed that financial barrier for 130 million women and men across the country, which is massive, but there's
huge.
still a huge gap that exists, which is why we need this federal law to have consistent coverage for everyone, no cost coverage for everyone across the country.
I'm curious what they found in those states, because I know the concern is it would raise costs. So that women would, for some reason, suddenly rush out to get ultrasounds and MRIs because it's like a
That's what
massage
we all
or
want,
something.
right? More testing is what everyone
Right,
wants.
it's so much fun.
Right.
The data has come back in pretty much all of those states that have done cost analyses that the cost is minimal. The cost to the insurer is minimal, and the increase to premiums for individuals is nominal. And again, I think that goes to what we heard earlier and what we all know. If you catch cancer earlier, it's not only better outcomes for the individual, but it's less expensive for that person, and it's less expensive for the healthcare system overall. So the cost fear hasn't materialized, and interestingly, when we first started these efforts, and Joanne and I have been working in many of those states together, but when we started those efforts, I would say the insurance companies came out in full force, everything against getting these bills passed. And I think the data has shown that perhaps there's not as much fear as there should have been. And so there's still some opposition, but it's not at the level that we have seen historically, most recently.
Because it's saving lives through early diagnosis and therefore saving money to the healthcare system at large and to the insurance companies, one would assume.
Absolutely.
Right.
Yes.
Joanne, you mentioned earlier in your first comments, you support not only the ABCD Act, but the Find It Early Act. And I don't think we all in the room know what the difference is between the two. Could you explain that? And would the passage of either one be equally helpful?
So they're both federal bills to expand and reduce the out-of-pocket costs associated with screening and diagnostic imaging, both based on NCC and guidelines. The Find It Early Act covers federal plans like Medicare, VHA, and TRICARE. So it would include, in addition to the private plans, some of the federal plans.
Okay, so the ABCD Act does not cover those.
Yeah, so the ABCD Act was introduced first. Again, it was introduced in 2019. And when we talked to committees of jurisdiction, there was more willingness to move forward a bill that was focused on this private insurance component. We absolutely agree that it needs to be addressed across the landscape, but again, things move slowly in DC, and larger scope bills can be more difficult to move. And so when Find It Early was introduced a couple years ago, we still felt it was important to reintroduce and continue to push ABCD, because if we can get a bite of the apple for private insurance, and it will make it easier to get coverage in Medicare and through TRICARE and other federal regulated insurance. But we worked with Deloro's office on the language is purposely very similar because we felt it really important. Again, the issue remains that we need access to supplemental and diagnostic without the cost. So they are very, very similar in text.
And can I just say this, no matter what passes and no matter how hard we work, none of these efforts is going to stop these women from getting breast cancer.
Right.
And so the question is, when are we going to find that breast cancer? Are we going to find it when maybe she has a lumpectomy and she goes back to work the next day? Or when now we're talking about a life-threatening illness and her kids losing their mom and a family losing a family member? When are we going to find it? And so that's the question. And so early stage cancer is easier to treat and saves these families and keeps them intact. And that's the whole purpose. I mean, screening is either important or it's not. And the reason we screen is to find it early.
And it's really unfortunate that we even have to talk about this. I mean, it's crazy. I forgot to mention something that we also do is that, it's really important to be in the community, and that's what Komen does, and that's what we do every day. And we do about 100 events across the country, and at about 30 of the events that we can afford, we do screening at our events. And we screen young women. We particularly screen young women who are under 40 because they can't get a mammogram. And so we have a lot of different things that we use to do that. But for example, we went to Martha's Vineyard last year, kind of where all the bougie black people go in August. It's like a thing. The black people know what I'm talking about. And we scanned, we did BEXA scanning on 55 women. We found 3 cancers in 3 days. This year we did it again. We scanned 158 women and we found no cancer, thank you God. But I think we were in the community, and actually 40 of the women that came back from year to year to get scanned because it was easy for them to do. They're on vacation, but we try to bring it to the community so they don't have to do it themselves. But I think it's really important just to talk about it and be where people are and meet them where they are to understand the importance of this.
Christine, I was wondering if you could look down the road, really to the future for us regarding imaging, and are there any innovations that hold really great promise, say over the next 5 to 10 years, to improve early detection, to reduce false positives?
Yep, there sure are. As I mentioned previously, one of the key issues is figuring out who needs something extra, be it ultrasound or MRI, and when do they need it. So there are some really promising research studies coming down the pike. Most of us in the room by now are familiar with AI, artificial intelligence. Within that subset, that large umbrella, we have machine learning, and then under that, we have deep learning. And we won't go into the weeds on that today, but basically using these neural networks, these very advanced computer algorithms, to either take a single imaging feature. For example, there are these amazing studies showing that using a single mammogram, we can predict with better accuracy than, say, all of the online math models that we have right now, not only who is at elevated risk of breast cancer, but when, narrowing it from a lifetime risk to a 5-year period. So that's huge.
And that's using AI?
That's right. That's using AI, just with a mammogram image. Not only that, it is more racially, ethically equitable than the models that we have online now that have always underperformed in certain populations, including Black women, Latino women, partly because they were not developed and tested in those populations. So not only are these better tools, they're equitable tools, there are some also really interesting studies that if we combine that with a few very interesting but easy to get facts, where you live, what neighborhood you are from, right? Your neighborhood deprivation index, your family history, et cetera. Information that should be pretty easily accessible. Combine that with an image, these models are amazing. So obviously that's not in clinical use right now, but it could be in the near future. The studies are amazing.
I would say, though, that I get calls every week about, so my doctor said if I pay an extra $40, I can get the AI mammogram. Should I do that?
I'm getting one in like 2 weeks.
Yeah.
What's the deal? Is that,
And I said, well,
I said yes.
And so, no, you should. I said, if you can afford it, yes, do it. But still, I don't think we have data to validate that we have enough Black women in that research to make a statement about it. So I say do it because we need your data.
Yes, and I will add those tools, CAD, for example, that helps radiologists see calcifications, et cetera, sometimes get lumped in with those AI mammograms.
Right.
And that is not the same thing as what will hopefully be coming down the pike and is not yet available now. In the shorter term, we have contrast-enhanced mammo, which is similar to MRI in that you get intravenous contrast and then you get a mammogram.
So who would need that? Who is that good
Great
for?
question.
Women with dense breasts?
Yes. So the data is lagging a bit behind. It's a newer technology than MRI. It is not quite as good as MRI, early data shows, but it's pretty good. And already it's in use for diagnostic imaging. For example, in women who have dense breasts, you get recalled, there's something vague there, you want contrast. And or women who can't get MRI for various reasons. Screening studies are pending. There's lots of data coming, but it has a lot of promise. It is a shorter study, a less expensive study, fairly tolerable to most patients. So that is also another very promising avenue. It has the benefit of not just relying on anatomy, right? So when we do mammogram or ultrasound, we are simply looking at anatomy, just looking at tissue, shapes, things like that. Both MRI and contrast-enhanced mammogram are looking at enhancement, so blood flow. Tumors have increased blood flow. So basically, for lack of a simpler explanation, they light up on an MRI or a contrast-enhanced mammogram and potentially improve the accuracy. So that is hopefully in the near future.
And it sounds, I would assume quickly, the contrast-enhanced mammogram is less expensive than an MRI.
That's correct, yeah.
I would also add contrast-enhanced mammography is really important, especially when you're looking at rural communities that don't have access to this other imaging, an MRI machine. And so we have disparities across the board in breast cancer, but another significant one is individuals in rural populations. And so CEM, contrast-enhanced mammography, is really important for that.
Yeah.
And again, included within guidelines for those purposes, so covered by both the ABCD Act and Find It Early.
80% of patients are going to community hospitals, so they're not going to Georgetown and MD Anderson. They're going to in their community where they're probably not having access to this kind of technology.
As we wrap, I'd like us to look kind of a little bit, as Christine just did there, look down the road into the future. Is there something on the horizon in breast cancer, detection, treatment, whatever, that you're excited about? Something you want to put on our radar?
For me, it's clinical trials, because we don't have enough Black women in research across the board, whether it's for diagnosis, treatment, whatever. So any clinical trial is important. We actually launched a clinical trial education campaign a few years ago, 4 years ago, called When We Trial. If you go to whenwetrial.org, and we have a portal where we recruit women to trials, all kinds of trials for breast cancer. Yesterday, we actually hit 30,234 Black women have hit our portal. So that was a pretty big accomplishment for us. But we still have more work to do. And I think that we just need more data about Black breast cancer across the board, whether it's for screening, for treatments, for anything. And so we.
And do you have scientists lining up to do research with that data?
Yes, we do.
When you get it?
We do. We're part of a Cancer Grand Challenge right now with a researcher at Morehouse School of Medicine, Melissa Davis. So we are studying the disparities between Black and white cancers across the globe. It's a global study. We're in the U.S., the UK, Canada, Nigeria, Ghana, Nigeria, South Africa, Ethiopia, Kenya, and Zambia. And we're trying to understand why our cancers are different. But there's not enough research like that, and we need more. So I would say just science is really important.
Molly?
So I would echo that, but to layer on, we also know our scientific advisory board has advised us many years ago that when you look at breast cancer mortality, we can reduce the number of breast cancer deaths by 1/3 by just getting people access to the care we have in existence today. And so with my policy hat on, right, that's what I'm most excited about, is to be able to get these policy changes done so that all people can access the care they need when and where they need it without financial strain, without the administrative strain that we heard earlier, having to go get a script or, having to have prior authorization and all these other barriers that patients face. So really looking to policymakers, whether that be at the state or federal levels or within the regulatory space, to work together with us to ensure that all people have access to what we already have today, right? It's crazy that we have it available and we could save 1/3 of the 43,000 people that are dying just by getting them connected to the existing treatments and screening and care that we have available now.
Joanne?
I think all of that, yes. But I think that there needs to be some sort of more standardized approach to getting women involved in the screening program. All women at 25 should have a conversation with their health care provider about their personal history, and even a benign biopsy matters and increases your risk. Family history, her breast density, to know who should be in that high-risk channel and who should be discussing supplemental screening and what that should be. So that involves an educated patient. It involves her referring provider who understands how to assess risk, how to identify the high-risk patient, what to explain to them and what they should do. And once we get her in that office and she agrees and the doctor agrees that she should have something else, then the insurance should be there to cover that without costing her $1,800 a year for an MRI. And we hear from women every day that write into the website, I was sent on for the MRI, it was $1,800, they tell me I need it every year, I'm a single mom, I can't do that every year. And so what could be crueler than telling someone you're at elevated risk and need this screening and, well, now good luck, It's horrible.
Happens every day.
Right. And Christine?
Again, I'm struggling to pick just one that I'm excited about, but I think locally, what do I mean in my institution and my city and surrounding areas, I'm excited about some really promising strategies that we have rolled out and will continue to study and expand on to deliver the care. It's simple, to deliver the screening efficiently and get them to diagnostic and biopsy quickly, and subsequent treatment, of course. That's the end goal. Strategies like mobile mammography, specifically bringing the care to the patient, screening in their neighborhood, and hopefully eventually diagnostic too. Hospital level care, things like bundled or conditional order sets, where our providers can enter a single order that can allow the patient to go straight through in a single day, screening or at least diagnostic, straight to biopsy, and then connected to our cancer center. So those kinds of local interventions are really exciting. More broadly, I am really excited about the research. I feel like it is at our fingertips to be able to have strategies to better identify who needs screening, what they need, and when they need it. And equitable strategies, because we have made the mistakes in the past where we have done research on a very undiverse population, and we can make sure at this point that we do not repeat those mistakes. So I'm really excited about that as well.
Wow, what an amazing discussion. Ricky, Molly, Joanne, Christine, thank you. Thank you so much. Thank you all of us here in the room for joining us, those who are watching live. And And a big thank you to our sponsor, the Alliance for Breast Cancer Policy, again, for bringing us all together. And if anyone missed a portion of this, someone who was watching or you want a friend to watch, the full event video is going to be available on thehill.com. So thank you. Have a great day. If you're a woman of eligibility age, go get your screening. And if you're not, tell the women in your life who are to do it. Please help save their lives.
Thank you.
Thank you.
Thank you, Kristen. Thank you.